after listening to such a beautiful talk on genetics by Dr. Shefali. It's a very common topic among physicians, and unfortunately in post-lunch session I hardly see any physicians available here, very few. But anyhow, the topic allotted to me is this, so I go into this topic for my talk. The father of toxicology, Paracelsus, defined that all substances are poisons. The right dose differentiates poison from a remedy. If we go to the toxic epidemiology of poisoning in Indian population, a 10-year meta-analysis showed that out of the all cause of poisoning, pesticides constitute 63% of the all poisoning cases. And if we go back in studies from Punjab, I could not find any new data from any chemical lab. They said it's not being given to common people. And in year of 2016-17, out of 2,000 samples studied in a lab, out of this almost 50% were of aluminium phosphide and 40% were of organophosphorus poisoning. There has been earlier seen a very increasing trend of deaths due to pesticide poisoning in Punjab till 18. After that, I don't know the figures, maybe the incidence gone down because a lot of migration of youth from Punjab to overseas countries, because suicides were quite common among youths earlier. General management of acute poisoning. I will be covering under resuscitation and initial stabilization, diagnosis of type of poison, prevention of absorption, enhancement of elimination, specific therapy by antidote if it's there, and supportive care. The first and foremost part is resuscitation and initial stabilization, which comprises basically the ABC, airways, control of breathing, taking care of oxygenation, maintaining of circulation with fluids or vasopressor wherever they are required. Earlier investigation of metabolic abnormalities and ABG is very essential in such patients. Sometime in comatose patients, and the coma cocktail comprising of dextrose 25 or 50%, oxygen at high flow rate, naloxone, which is very useful in opioid-induced coma, is common. Then in alcoholics, thiamine has also been found very useful. Flumazenil is another drug which has been useful, found in earlier time at immediate admission to the emergency in patients of benzodiazepines toxicity. For the diagnosis of type of poison, if we go by the toxidromes, various toxidromes, we can be early detect the type of poison, like cholinergic toxidrome in opiates and carbamates, anticholinergics in datura-like compounds, adrenergic in amphetamine-like compounds, opiates and narcotics toxidrome. The earlier cholinergic toxidrome, as the undergraduates remembered, like all muscarinic effects, they remember by Dumble, diarrhea, urinary incontinence, meiosis, bradycardia, bronchoconstriction, lacrimation, and the nicotinic effects. The important one are weakness of the muscles and tremors, weakness of the muscle leading to respiratory paralysis. Anticholinergic toxidrome are important in datura-like poisonings, atropine-like poisonings, flushing, dry skin, mydriasis, confusional states, urinary retention, and tachycardia. Adrenergic toxidrome, patient is very agitated, having tachycardia, hypertension, hyperthermia, sometimes can have seizures also, and psychotic behavior. Narcotic toxidrome, so common, opiates and other opioid-like synthetic drugs. Patient having meiosis, altered mental status, shallow breath, bradycardia and hypotension, hypothermia. Withdrawal toxidrome with alcoholics and benzodiazepines and opiates, again very common presentation. Having mydriasis, diarrhea, tachycardia, lacrimation, hypertension. Seizures are very common in ethanol or benzodiazepines withdrawals. And initially you can identify some of the toxins from their characteristic order also, and like garlic kind of a smell in organophosphates compounds, rotten egg with sulfur dioxide, and systemic examination, the neurological examination in patients of poisoning is very patchy involvement. So instead of the other, like we do neurology examination in other comatose patient in suspected poisoning, just keeping 4 simple words: alert, verbal response, painful response, or unresponsiveness. You can just go on to measure these simple things for such patients. Meiosis pupils are very helpful. Meiosis used in cholinergics, opiates, sedative hypnotics, and mydriasis in anticholinergics and withdrawals. Seizures are very common in the earlier stage in organophosphates, oral hypoglycemic agents, amphetamines, and ethanol withdrawal, and lithium poisoning patients, and also in lead poisoning patients. We commonly see lead poisoning because of, again, indigenous drugs used by the youngsters. 3 lab investigations or gaps are very helpful in toxicology: anion gap, osmolar gap, and oxygen saturation gap. So anion gap, increased anion gap is seen in patients who especially having a lot of metabolic acidosis with methanol and ethanol and salicylates poisoning. It's again very helpful in identifying underlying poison. Osmolar gap is very helpful, and it's especially useful in emergency in patients of with unaltered sensorium, because there are some it measures the measured osmolality and minus calculated osmolality. You can measure the calculated osmolar gap. It's increased because of the osmotically active substances in the blood. It's very useful early diagnosis of methanol or ethanol poisoning. Methanol poisoning recently has been very common in some parts of the Punjab. Oxygen saturation gap, especially helpful in carbon monoxide poisoning, where there is a difference of more than 5% in the saturation of ABG and the co-oximeter. Urine tox screen test is helpful these days. The DOP test, which commonly is done in several hospitals for examination, it's helpful sometimes, especially in opiates and some other drugs which the individual may be using and having its toxicity. So in the treatment, the prevention of absorption in the initial stages is very important. Apart from a decontamination and the prevention of absorption from the gastrointestinal tract, gastric lavage, which was very commonly done in earlier stages. So no clear-cut evidence of clinical benefits have been shown in retained drug patients, and only in patients who have a very toxic substance and has ingested very recently in 1 hour, it's most helpful in those patients. Some of the contraindications to gastric lavage means corrosives, hydrocarbons, toxicity, coagulopathies, or loss of airway reflexes, because again gastric lavage is associated with many complications. Sometimes it increases the admission to the ICUs. Techniques of gastric lavage, everybody knows. Only small aliquots of liquid, normal saline or water can be used for this. Activated charcoal has been recommended. Again, the beneficial is again in the first hour. It's not recommended in metals, alcohols, or hydrocarbons. Whole ball irrigation has been useful only in substances who are enteric coated drugs, slowly dissolving drugs, ingested packets of illicit drugs. Then we come on to enhanced elimination. Methods are urinary alkalinization and multi-doses of activated charcoal or extracorporeal remover with hemodialysis or hemoperfusion. Urinary alkalization, it's more helpful in salicylates, phenobarbital, or lithium compounds of poisonings. The usual method with IV fluids, glucose with soda bicarb, but be careful of hypokalemia in such patients, and it is again contraindicated in patients who are in shock, hypotension, renal failure, or in congestive heart failure. Extracorporeal remover, hemodialysis is very useful in many of toxic substances, especially where there is a low volume distribution, the toxin having low protein bounding, high water solubility, and is useful in alcohol, salicylates poisoning, barbiturates poisoning. Hemoperfusion, the toxin which are having Lipid solubility, it's more useful, it's a extracorporeal removal method. There are specific antidotes, like we have atropine and PAM for OPC poisoning. We have certain other, like flumazenil for benzodiazepines, naloxone for opiates, fomepizole or ethanol for methanol poisoning. Supportive therapy is always the key. Antidotes are only for few toxins. Treatment is largely supportive. Aim is to preserve the vital organ function until the poison is eliminated. Therefore, support of function of systems and prevent complications, the mainstay. Monitor the fluid, electrolytes and acid base very closely. Few of the common specific poisoning in our area, the OPC and carbamates and organochlorous compounds are very common. Typically, we see muscarinic, nicotinic and CNS effects and OPC and carbamate poisonings. And organochlorous compound poisonings only we see CNS effects, muscarinic and nicotinic effects are not there with organochlorous compounds. Mainstay of treatment in OPC poisoning remains decontamination and atropine bolus dose followed by the dose till atropinization is achieved. The only thing is it should be very withdrawn, gradually withdrawn, maybe up to 72 or 96 hours. Early withdrawal of atropine leads to recurrence of symptoms which can be fatal. Pralidoxime, initial as early as possible should also be used. 1 gram initial dose followed by 0.5 to 1 gram 6 hourly for next 24 hours. These are not required in carbamate, so be careful for this also. Aluminium phosphide poisoning and very common poisoning and having a mortality, high mortality which can occur within 12 hours of ingestion. Patient presenting with the common symptoms of nausea, vomiting, having garlic odor, rotten fish odor. Early hypotension and shock is very common. It's due to because of extensive capillary damage leading on to hypovolemia and decreased cardiac output. It's a directly myocardial toxic drug. Because of the pulmonary hemorrhage leads to early ARDS, leading to metabolic acidosis, hypokalemia, hypomagnesemia, and even calcium levels are also very low in aluminium phosphate poisoning. So very early treatment has to be started. Gastric lavage with mild oxidizing agent can be done with KMNO4, followed by copious lavage with soda bicarb. This will help that we are not loading the patient with soda bicarb. We have to take care of this. Early fluid therapy guided by CVP should be done. Inotrope should be used as per requirement. This drug leads to a lot of cardiac arrhythmias because of direct myocardial toxicity. So arrhythmia specific therapy, magnesium sulfate is very helpful in these patients, should be used early. Initially we can give 1 gram, then followed by every 6 hourly. Calcium gluconate and KCl as per the serum concentration should be given. Then comes the ARDS, which is with the oxygenation and ventilation. Methyl alcohol, the huge tragedy which is commonly occurring in areas of Punjab. It's very common poisoning these days now. Initially the patient is having mild drowsiness, then abdominal pain, vomiting, leading to again when acidosis comes, cosmal respiration, papilledema and seizures, eye involvement, direct retrobulbar neuritis can occur, coma and death. So treatment again, fomepizole is not available in India. Cost is very high for a 15 milligram dose per kg body weight. A 15 milligram ampule, 1500 microgram ampule almost costs $1,000 US. So it's a very costly drug. It's not available in India. In India, apart from the large amount of IV glucose, vitamin B1 and B12 with metabolic acidosis correction with soda bicarb, the mainstay lies here is ethanol. So patient of alcohol poisoning is being treated with alcohol here. So ethanol, because of very high affinity for the enzyme ADH, alcohol dehydrogenase, It has got, ADH has got 15 times more affinity for ethanol as compared to methanol, because methanol lead on to converted to formaldehyde, formic acid, which leads to acidosis and the complication. Again, IV ethanol is very not commonly available, and you have to monitor the ethanol levels also therapeutically around 100 milligram per deciliter. So oral ethanol is given in such patients. You can give oral ethanol with Ryle tube around 50%, almost all ethanol alcohols are available with 40 to 50% of the ethanol. So we can give around 2 ml per kg is the dose. You can mix it with the fruit juice and can be given. Here hemodialysis is as early as possible, especially when patients in coma, having seizure or visual loss or leading to visual disturbances, so that you can prevent the death in such patients. So take home points: treat the patient, not the poison. Identifying the poison with the toxidrome is the key to diagnosis. Resuscitation and initial stabilization is most important step. Coma sometimes can be life-saving. Thank you.